Hey everyone, today we've got another brilliant case study for you. This patient has low back pain, so we're going to help your clinical reasoning by talking you through our assessment, how we came up with the diagnosis, and how we came up with our rehab plans and strategies to help this patient. If you're ready to learn, let's dive in. Hey everyone, welcome to today's case study. Let's go through the subjective history to start with. So we have a 44-year-old patient who presents with low back pain and left-sided leg pain. And this leg pain goes all the way from his buttock, down the posterior leg, and all the way to the foot. His symptoms started 1 month ago when he went to pick up a box and felt a sudden sharp shooting pain in his back running down the back of his left leg. His symptoms have been the same for the last 2 weeks. They got worse initially, but now they've been similar at the same level for around the last 2 weeks or so. So his main symptoms now is this sharp shooting pain in his left leg, which he feels is relatively constant in its nature. There's always something in the background there, and then he will get this sharp shooting pain that really irritates him. He's also getting intermittent pins and needles in the lateral side of his left foot around the fifth toe. So what here are his main aggravating factors? Well, the key things that we're finding when we go through his aggravating factors in his history is that it seems to be flexion-based activities that makes things worse. When he's sitting in a chair, when he's driving, when he's trying to pick things up from the floor. So it seems as if there's this flexion-based pattern to his symptoms. Thankfully, he reports no red flag symptoms. He reports no indications of any cauda equina signs, such as issues with controlling his bowel or bladder, numbness around his private areas, etc. So, thankfully, no serious signs going on, but clearly his symptoms are really irritable. So then we go through our objective examination. Let's discuss it. So first of all, your patient walks in unaided with no walking sticks or crutches, but he does have an antalgic gait. He's limping and it looks like he's trying to walk and stand with his left knee flexed, which is probably a response because of the fact that when he tries to straighten his knee when he's walking, it becomes more painful. So then we look through his active range of movement. So first of all, we look at lumbar spine extension and side flexion to the right and left sides. These movements are not full, as you can probably imagine for someone with low back pain, but crucially, they don't seem to worsen his leg symptoms. However, we find that lumbar flexion clearly does aggravate both his back pain and his leg pain, and he only has half range of movement here, where he's reaching to just below his knee with his fingertips. Thankfully, when we assess his hips in terms of passive range of movement, there doesn't seem to be any major restriction there. Then we go through our neurological assessment, which we should do given that he has these symptoms running down his posterior leg all the way towards the foot. So we don't find any changes in his sensation on dermatomal testing, but on myotomal testing, it's clear that he has weakness in his left plantar flexors, and if we are looking on the Oxford scale, left plantar flexion is only scored at 4 out of 5 in terms of strength. Otherwise, all his other myotomes are 5 out of 5. We look at his reflexes. His knee reflexes are normal on both the right and left sides. However, his ankle reflex is diminished. It's hyporeflexive. Hypo means low. He gets less of a reflex on the left side when we're thinking about his ankle reflex. We also complete a straight leg raise for him, which is the test that you can see me performing on the screen there. And we find that when we get to around 30 degrees, it clearly aggravates his left leg pain. So it seems as if there's an irritation there. So that's his subjective history. That's his objective examination. Pause the video and have a think about your diagnosis for this particular patient. So everyone, I really hope that you've enjoyed this case study. Let's go through our answers. So the diagnosis that we had for this patient was that he had a clearly painful left-sided lumbar radiculopathy. When we describe a radiculopathy, we mean that there is a nerve root compression. And the reason that we know that is because there is either dermatomal changes, myotomal changes, and or reflex changes that would indicate that that nerve root is being compressed. And because of the clinical examination that we have, we suspect that this nerve root compression is occurring at the S1 level on his left side. Let's go through why. So first of all, we know that there is a neurological component to this patient's symptoms. First of all, he describes pain which is very neurological in its description, a sharp shooting pain. And this is what patients will commonly describe when they have neurogenic pain, either shooting, electric type sensations, lancinating, or a burning kind of sensation. And this patient certainly has this sharp shooting pain, which is clearly neurogenic in its nature. This combined, of course, with the fact that he presents with pins and needles and the fact that he has increased sensitivity of his sciatic nerve with that straight leg raise. The fact that we can only get to 30 degrees before it aggravates his leg pain is clear that there is a neurological component here. Now, the key thing with that straight leg raise that you're looking for in your practice is a reproduction of your patient's specific symptoms. So if we did that test and he said, oh, it just feels a little bit sore, but it's not too bad, that's less convincing than if he says, yes, that's exactly the pain that I get in the back of my leg. It's sharp shooting running all the way down to the foot. That is my pain. When you get a reproduction of your patient's symptoms, it's more likely to be a positive on that test. Then we look at his dermatomes, myotomes, and his reflexes. Now, we noticed that with the dermatomes, there wasn't any lack of sensation on testing. However, what we do know from his subjective assessment is that he gets pins and needles on the lateral side of his left foot, which fits in with the S1 dermatomal distribution. We then think about his reflexes. The Achilles reflex is reduced on his left side, and the Achilles reflex tests the reflex at the spinal level S1, S2. Finally, when we look at his myotomes, we know that his plantar flexion myotome is weaker on his left side. And we know that the myotome associated with the S1 level is plantar flexion. So, we've got sensation changes in the S1 distribution, a reflex which is diminished at the S1 spinal level, and the S1 myotome is reduced. That's how we know that the nerve root compression is suspected to be at the S1 level. So, therefore, that's the diagnosis. What did we do to help this patient? Well, the first thing that's really important to establish is whether or not your patient's symptoms are worsening or not. And that's because we should take a different approach to his care if we find that his symptoms are neurologically worsening, and we'll talk through that in a minute. But because his symptoms are not worsening, we said in the subjective history that he has noticed that his symptoms have been the same in the last 2 weeks, we are free to proceed with physiotherapy in the first instance. So we trialed lumbar extension exercises, and the reason being is we saw in his objective examination that lumbar extension did not make his symptoms worse, but also we know that flexion is clearly his aggravating factor. So what I would normally do in this situation is trial lumbar extension exercises with the patient in clinic. And I want to make sure that I'm going through with them so they know the technique, they know what to do, and also because I want to make sure that it's not making their symptoms worse. And thankfully for him, we were able to do that, and his symptoms were not aggravated. In fact, he said it felt a little bit better doing those exercises. Then we are trying to do things to keep the patient moving. It's really important that we educate patients like this that staying still, doing nothing, lying in bed, sitting on the sofa is not going to help their symptoms. If anything, it might make it worse. So we try and keep the patient active as their pain allows. So if they enjoy going for a walk, we get them to go for a walk. If they enjoy swimming, we get them to go swimming. If we find that those things are too irritable, is there the exercises that we can give them to keep them active? So that's really, really important and great for your patient's confidence that they can keep moving. We also wrote back to their GP, their physician, to consider neuropathic analgesia, neuropathic pain medication. These are painkillers which are specifically linked to nerve pain, things like amitriptyline, pregabalin, gabapentin. And we suggested that we will watch and wait over the next few weeks, i.e. we're going to monitor them and see whether or not their symptoms get worse. If they do get worse, we'll act accordingly. And this is what we were talking about when we mentioned the importance at the beginning of our rehab strategy. Are the symptoms getting worse or not? So thankfully at the moment they're not, so we can proceed with physio. However, if when the patient comes back to see us, we find that their symptoms are worse, maybe their weakness has got worse, maybe their pain has increased, maybe they're showing weakness in other areas, or now they are showing dermatomal loss, that would be when we'd say, right, carry on with your exercises, but at the same time, we need to act differently. We're going to refer this patient on for a specialist spinal review, perhaps with a specialist physio or an orthopedic consultant, to consider whether or not an MRI scan is needed to see how much of the nerve tissue is being compressed, and therefore, does this patient need more urgent intervention to reduce their symptoms. And of course, we would always remember that we need to be screening for cord requiner symptoms at every appointment this patient has. And of course, if there was any suspicion that they had cord requiner syndrome, we would refer them urgently to the emergency department. So everyone, thank you so much for watching. I really hope you've enjoyed this case study. If you have, please support us by smashing that like button and subscribe to the channel for all our best updates. Remember, we've got loads of brilliant resources as well on our Instagram account, @ClinicalPhysio on Instagram. And if you want more case studies, check out membership in the description below, because as a part of Clinical Physio membership, you get access to the Case Study Club, in which we go through lots of case studies with expert physios, giving us all the clinical reasoning behind why they do what they do with their patients. My name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.